Hello, my name is Eric Senneville. I am an infectious disease working in France, and I will present to you a summary of the recommendations from the last IWGDF, IDSA, Infectious Disease Society of America, 2023 guidelines on the diagnosis and treatment of foot infection in persons with diabetes. To treat diabetes-related foot infections, we have 4 important parts to consider. The first one is to diagnose infection, its presence, its severity, the type of tissues involved, I mean soft tissue versus bone tissues. And it is very important to assess the vascular status of the foot because of its importance in terms of prognosis and risk of amputation. The second part is to obtain appropriate cultures, and tissues are preferred to superficial samples, I mean swabs, and bone samples are preferred for osteomyelitis. Surgery is a very important part of the treatment of these patients, and it is based on debridement, drainage, bone resection, sometimes amputation, and again revascularization when it is needed is really important. And the fourth part is to select antibiotic treatment, and antibiotics are useful even if the option is surgical, because we need antibiotics in every infectious situation of the foot. There are 2 parts. One is empiric, the initial part of the treatment, before we have the results of the sample culture, and the definitive is based on the culture results. So the first point is to diagnose infection, and it is recommended to diagnose a soft tissue infection clinically, not microbiologically, but clinically, based on the presence of local or systemic signs and symptoms of inflammation. This is a strong recommendation regarding the grade, method, and the certainty of the evidence is low. And to assess the severity of the infection, once it has been diagnosed, we recommend to use the IWGDF IDSA classification scheme. This classification is the following. It is based on 4 grades. Grade 1 is the absence of any signs suggesting an infection or symptoms. Grade 2 is a mild infection. It means that there are signs of local inflammation defined by the presence of an erythema zone less than 2 centimeters around the limits of the ulcer. Grade 3 is defined by the extension of the inflammation on surface more than 2 centimeters from the limits of the ulcer, so presence of an lymphangitis. And the second option is an infection with an extent in depth deeper than skin, abscess, arthritis, osteomyelitis, fasciitis. And grade 4 is a severe infection defined by the presence of systemic signs of toxicity or metabolic decompensation and the presence of SIRS, the systemic inflammatory response syndrome. In case of the presence of osteomyelitis, and because of the importance of osteomyelitis in terms of treatment and outcome, and again the risk of amputation, we recommend to add a no in grade 3 or grades 4 when there is an osteomyelitis. It is really important to define the presence or the absence of an infection, because in grade 1 we don't need any antibiotics, and in grade 2 we need antibiotics. We don't have any data showing that the use of systemic or local antibiotics may have an impact on non-infected ulcers. And it is important to consider this definition again to limit the unjustified use of antibiotics and the risk associated with these treatments. Microbiological assessment for soft tissue infection, we recommend to consider a sample for culture to determine the causative microorganisms, and preferably by using an aseptically collection of a tissue specimen by curettage or biopsy from the wound. And we do not recommend the use of swabs, because the superficial samples are not able to differentiate contaminants from true pathogens. For soft tissue and DFO, we recommend not to use molecular technique for the identification of microbes and to consider the standard culture of the samples. Just because these techniques are expensive, they are not available everywhere, and at the moment, we don't have data showing that this technique may improve the patient's outcomes or may have a significant impact on the use of antibiotics included in the antibiotic stewardship. Probably we will have this kind of data in the future, but for now we don't have this data. The reason why we do not recommend the use of these molecular techniques. Regarding the diagnosis of osteomyelitis, when you have a suspicion of a bone involvement, we recommend to consider the use of a combination of the probe-to-bone test using a sterile blunt to have a bone contact, to use plain X-rays as a first imaging technique, and one of the classic inflammatory biomarkers such as the erythrocyte sedimentation rate, CRP, procalcitonin, to diagnose osteomyelitis of the foot. This is a conditional recommendation with a low certainty of evidence. In case of a suspicion of osteomyelitis of the foot, we recommend to consider obtaining bone rather than soft tissue samples for culture, either intraoperatively or percutaneously, just because the correlation between superficial, non-bone samples and bone samples is not very good, and given the difficulty to treat these patients, we consider it's better to have this kind of bone samples to have good data to provide the patients with the most appropriate treatment, especially because it is usually a prolonged treatment in this case of TFO. Regarding antibiotic treatment, very importantly, do not treat clinically an infected foot ulcer, this is a repetition, with systemic or local antibiotic treatment when the goal is to reduce the risk of new infection or to promote ulcer healing, just because, again, we don't have any data showing the benefit of this treatment, and because of the risk of negative effect, collateral damage of this treatment. This is a best practice statement. Regarding on the antibiotic treatment, we recommend to administer antibiotic treatment to a patient with a soft tissue infection for a duration of 1 to 2 weeks, and in some situations, prolonged treatment, not more than 3 to 4 weeks, could be considered if the infection is improving but is extensive at the beginning and is resolving slower than expected, or if the patient has severe peripheral artery disease, because this is probably a factor likely to decrease the amount of antibiotics at the infected site. This is a conditional recommendation with a low certainty of evidence. It is important to provide the patient with the date of the end of the treatment, because it is important to keep in mind that the date of the end of the treatment is not the days of the complete wound healing. So it's very important to define the end of the antibiotic treatment and not to prolong until the wound is healed. Again, regarding the antibiotic treatment, we recommend to consider up to 3 weeks of antibiotic treatment after minor amputation for diabetes-related osteomyelitis of the foot and positive bone margin culture when it has been performed, and not more than 6 weeks for diabetes-related foot osteomyelitis without any bone resection or amputation, medical treatment of this diabetic foot osteomyelitis. Regarding follow-up of these patients treated with an osteomyelitis, we consider that 12 months follow-up in order to assess the outcome of this DFO seems to be a bit long, just because there are many causes of the recurrence of a new ulcer that may result in a new infection and in a new episode of osteomyelitis. So we propose to reduce this minimum follow-up duration to 6 months. To 6 months rather than 12 for these reasons. This is again a best practice statement. In people with diabetes, peripheral artery disease, and a foot ulcer or gangrene with infection involving any portion of the foot, we recommend to obtain an urgent consultation by a surgical specialist as well as a vascular specialist in order to determine the indications and timings of a drainage procedure and or a revascularization procedure. This is a best practice statement. We recommend to consider antibiotic treatment without surgery in case of a forefoot osteomyelitis without an immediate need for incision and drainage to control infection, and without peripheral artery disease, and without exposed bone. This is a new recommendation in the sense that we have broadened the indication of medical treatment of diabetic foot osteomyelitis, given the data we have now in the literature showing that in some selected patients we can treat this kind of osteomyelitis without any surgery. I mean without any bone resection. But again, these patients have to be selected before taking this kind of decision. So we'd like to thank you for your attention, and these guidelines are available on the website of the IWGDF. Thank you.